Osteoporosis is considered the silent disease and a silent thief. It is a chronic metabolic bone disorder. There is loss in bone density. The bones become more porous. It increases the fragility of the bone, puts the patient at increased risk for hip, spine, and risk factors. With this, you will see more patients that actually they'll have the pathological fracture causing the fall that breaks the hip instead of them falling and then breaking the hip. A lot of times you'll see that with osteoporosis. A lot of times when these patients fall, they break their wrist trying to support their own weight as well. As I stated before, osteoporosis is sometimes referred to as a silent disease or a silent thief because a lot of times the first sign of osteoporosis in most people follows some kind of fracture, whether it be spine, hip, and wrist are the most at risk. Your European American postmenopausal women have a 50% chance of having an osteoporotic related fracture in their lifetime. Women who experience a hip fracture have 4 times greater risk of a second fracture. Fractures as a result of osteoporosis and falling can decrease a patient's mobility and decrease their quality of life. The mortality rate for older patients with hip fractures is very high, especially within the first 6 to 12 months. Osteoporosis is a major global health problem. It is seen a lot in countries that are in famines because of nutrient deficiencies. Risk factors for primary osteoarthritis. Primary osteoarthritis is more common and occurs in postmenopausal women and in men in their 7th or 8th decade of life. Non-modifiable risk factors include older age, genetic factors, and personal history of low trauma fracture after 50. Modifiable risk factors include if you're very thin, to build up some body weight and to build muscle mass. If you have an estrogen deficiency, taking the medications. If you're a smoker, to quit smoking, to make sure that you are continuing with physical exercise and try not to be immobile. Avoiding a large alcohol intake, and patients who have chronic low calcium and vitamin D levels, so they can take a calcium supplement along with a vitamin D supplement as well, will also be beneficial. Chart 50-1, assessing risk factors for primary osteoporosis, lists as the same things as the chart does, but it's listed just in a little bit different way. Again, this is on page 1017, and so that may give you something else to look at if you prefer to look in the book as opposed to the slides. But that is chart 50-1 on page 1017. It also talks about with the gender considerations for patient-centered care. We've already discussed it, but if you would like to look at those, it talks about primary osteoporosis most often occurs in women after menopause as a result of decreasing estrogen levels. Obese women can store estrogen in their tissues, and so it's usually you'll see osteoporosis more in thin, frail women. Now we'll talk about secondary osteoporosis. Secondary osteoporosis is as a result of other medical conditions such as hyperparathyroidism, long-term drug therapies with corticosteroids, and you see on table 50-2 common causes of secondary osteoporosis. So this would be a good place to look, but they're also listed here for as far as endocrine disorders, Cushing syndrome, diabetes, high alcohol intake, chronic use of medications such as steroids or high doses of thyroid hormone and some anti-epileptic agents. But the list is nicely put out for you in Table 50-2 on page 1016. This slide goes over more of the standards for diagnosis of osteoporosis based on MBD testing. This is well explained on page 1016 in our books. It's the last, starts in the last paragraph of the first column. You will not be responsible for this information, but I did want you to know, if you are interested in it, that that is there for you to look through. Clinical manifestations of osteoporosis. We will be responsible for these. When you're assessing for clinical manifestations of osteoporosis, look for loss of height. If someone is in for their general physical exam, you don't want to take a stated height. You want to make sure that at least once a year you get an actual height on patients. You'd be surprised at patients who think they're 6 feet tall and they're really, 5'11". Or in my case, I always said I was 5'2" and I'm really 5'1". But anyway, as they get older, they can lose height due to the kyphosis or cervical lordosis bending. You see here where they may be 5'8" at 40, but then by the time they are 60, you can see she's already shrunk to about 5'4". And then because of the severe kyphosis, by age 70, look how humped over she is. They will complain a lot of lower back pain that will occur sometimes if they're lifting, bending, or stooping. The pain may be sharp and acute onset. Pain is usually worse with activities and is relieved with rest. Back pain accompanied by tenderness and voluntary restriction of spinal movement can suggest one or more compressed spinal vertebrae. This is the most common type of orthopedic fragility fracture for these patients, and it's that vertebral compression fracture. And again, they complain of low back or neck pain, and that it is relieved some with rest. Diagnostic testing can include dual energy X-ray absorption, which is the DEXA scan. With this scan, they're not to have calcium supplements 24 hours before. MRI will look at bone quality because it can look at the yellow bone marrow and perfusion. If one has osteoporosis, the perfusion is lower than normal, and fat marrow content is higher in bone loss. Interventions for osteoporosis. There's a very nice chart on page 1021. I'm going to double check and make sure it is on page 1021. One moment, please. Yes, there is a very nice chart on page 1021 that talks about dietary supplements and other drug therapy used for osteoporosis. Other interventions is you need to assess for their risk factors. You need to educate on how to change modifiable risk factors, such as if they're inactive, getting them doing some type of walking. Safety is a huge problem with these patients. You need to make sure that they have a major concern because a simple fall can be detrimental. You want to make sure that they're using their call light, that they're using non-slip socks, that if they are in the hospital, they are on fall precautions. In the hospital and at home, they have a clutter-free environment. They wear their glasses to the bathroom. They don't try to go to the bathroom without their glasses. They should not have any type of throw rugs, and be very cautious of pets. In fact, some physicians will tell them to keep their pets put up at night when they're most unstable so that they don't trip over their pet. Make sure they're using good potty mechanics. Prevention is weight-bearing exercises. even just a simple walk or can help so much with that, but also tennis or hiking, just something that's more weight bearing if they can tolerate it. They need to eat foods that are rich in calcium, such as yogurt, milk, and so forth. Eat foods that are rich in vitamin D, such as salmon and tuna. You provide supplements if necessary. Sometimes the biophosphates can decrease bone breakdown and limit the life of the cast and prolong the life of the blast. It may cause GI upset if given on an empty stomach, so they're encouraged to take with a full glass of water, and wait 1 hour before giving food. I talked about this mostly with the other slide, but for nutrition, you want to increase their calcium intake, increase vitamin D, avoid excessive alcohol and caffeine. For lifestyle changes, you want to encourage them to exercise. Walking 30 minutes at least 3 to 5 times a week is the single most effective exercise for the prevention of osteoporosis. Again, I've already talked a lot about this. Continuing with safety, if they're in the hospital, you want to make sure that you are following fall precautions. At home, you want to make sure that we've taken up any throw rugs, that we have the paths are well lit. You want to make sure that they have stopped smoking, avoid excessive alcohol, and limit their caffeine. We've talked about making sure they have an adequate calcium intake and calcium-rich foods or calcium supplements. Make sure that they're injury prevention by avoiding twisting, bending, or lifting that can cause cervical fractures. We've talked about other safety precautions as well, as far as like throw rugs, making sure that they have a nightlight for the bathroom, and make sure they put their glasses on to go to the bathroom as well. Make sure that they're using their assistive devices to maintain their independence for ADLs. And listed below, again, are some of the medications that some of these patients may be on to help to combat their osteoporosis. The last few slides are NCLEX styled questions, and we will review those together as a group with our next meeting. And that's it. So you have this question about osteoporosis. The following question is about gout, and another question about gout. This is about rheumatoid arthritis and corticosteroid injections. And what patient teaching for a patient with osteoporosis. And assessment findings for the patient with osteoporosis as well. And strategies to help the patient with RA sleep better at night, as it may also be as questions that are there for you to look at.